my name is Kimberly Van Bergen-Hennegal. I'm going to demonstrate for you a shoulder dystocia birth on the birthing mannequin. I'm going to use the Royal College of Obstetrics and Gynecology algorithm for shoulder dystocia and talk about how it's slightly different to the AV algorithm as well. So shoulder dystocia is the arrest of spontaneous birth due to the impaction of the fetal shoulder behind the maternal pubic symphysis. Okay, so we're transitioning to the second stage of labour, and you're going to see an increase in anxiety, maybe some apprehension and some restlessness. So at this point it's really important to reassure mum and encourage her to stay relaxed as much as possible. So the second stage is the complete dilation of the cervix to 10 centimetres. And she's going to start telling you that she has an urge to push or she has some pressure in her rectum. So what you're looking for is anal pouting. Perhaps the vagina will start opening with each contraction and the perineum will thin out, bulge and move anterior. Cool, so we just wait for the, yeah, beautiful. So we're starting to see the vagina open with the contractions and just placing one hand on the head so it doesn't birth too quickly. Very good, encouraging mum to pant rather than push. And at that point, we're going to record the time of the head. So for shoulder dystocia, we're looking for the inability of the face or chin to be delivered. We're looking for turtle signs, so the in and out movement of the head without actual delivery of the head. We're looking for a failure to restitute or a failure for the shoulders to descend. It's clinically diagnosed by applying axial traction, so always axial in line with the spine, never down, as it can cause brachial plexus injury. So applying axial traction, and you're looking to feel for the inability of the shoulders to birth. So I'm pretty confident that we have shoulder dystocia, and at that point I'm going to communicate that to my partner and I'm going to call for help because we're going to need extra pair of hands. So you definitely don't want to do any pushing, panting only at this stage. Any pushing can further exacerbate that impaction of the fetal shoulder. Beautiful. So the first manoeuvre we're going to do is Mac Roberts. We do Mac Roberts first because it's highly successful and it's the least invasive. Mac Roberts is aiming to increase the relative anterior and posterior diameter of the maternal pelvis. And we do that by straightening out the lumbosacral angle, by rotating the maternal pelvis backwards towards the maternal head, like so. Beautiful. So you're going to want to encourage mum to come to the end of the bed, remove all pillows and blankets from underneath her, and you're going to help her flex her legs backwards to either side of her abdomen. And this is where your extra pair of hands will come in handy, helping her do so. She may be able to help you if it's only you or her, or maybe a family member. So you're going to know Mac Roberts has been successful in true Mac Roberts if her buttocks lifts off the bed slightly. So in that position, in the first Mac Roberts for 30 to 60 seconds, we're just going to apply axial traction like so, feeling for the release of that shoulder. Okay, after 30 to 60 seconds, that's failed. The next one we do is having your team member apply axial traction while you move behind the pubic symphysis. And what you're aiming to do is a downward and lateral pressure, just a continual pressure, and we're pushing the posterior aspect of the anterior fetal shoulder forward towards the chest to reduce the diameter of the shoulders. So 30 to 60 seconds behind the pubic symphysis like so, waiting for the release of that shoulder. Okay, so failing that, we can move into the next one, and that's just a downward pulsating type pressure for 30 to 60 seconds. Again, it's sort of a downward and lateral push to unhook that shoulder while your team member is holding axial traction. Lovely. Okay, so failing that, the Royal College of Obstetrics and Gynecology gives you a choice. Either go into the all fours Gaskin position or do an internal manoeuvre. Now AV don't recommend any internal manoeuvres, and the Royal College recommends that if you have a woman who hasn't had a epidural, she's quite mobile and perhaps you don't have as many people on hand, all fours is generally the one of choice. So moving her into all fours, the Gaskin position, that's actually quite successful in rotating the pelvis, and often the shoulder will unhook just in that position. So imagining she's on all fours, again, axial traction, not down, hoping for the shoulders to be birthed. Okay, failing that, I will talk briefly about the internal manoeuvre. Usually, or quite commonly, a fetus will come down the birth canal in a pharaoh type position, so one of their hands will generally be up around the neck. So what you can do is use a Pringle grip down the bottom, trying to reach for that fetal wrist and birth that posterior shoulder. Again, that reduces the diameter, and then the baby is able to be birthed. So we'll go all the way. Yep. Very good. So we've successfully unhooked baby, and the shoulders coming out, birth like so. Lovely. Onto mum's tummy. Lovely. And nice and warm. So there's a significant risk with shoulder dystocia, and that's for fetal death. So increased risk of resuscitation, especially if the fetus or the baby, hasn't been birthed within sort of 5 to 7 minutes. You also have quite a big risk of PPH, severe peroneal tearing, and the brachial plexus injury if pressure has been applied in a downward direction. So as normal, you've documented the timing of the birth of the head. You're going to document the birth of the shoulders, also any manoeuvres that you performed and for how long you did that for. At 1 and 5 minutes, you're going to do your ABGAR score, and we're going to encourage baby to be up near mum's nipples for a natural release of oxytocin, keeping them both warm at the same time. In AV, we do a physiological third stage, so no active management for the birthing of the placenta. So the birthing of the placenta happens about 30 minutes to 1 hour post-delivery of the baby. You're going to look for things like a sudden rise of the fundus, a gush of blood, or the lengthening of the umbilical cord. Beautiful. So, and we do practice a delayed cord clamping in the pre-hospital setting, but if the placenta is delivered before arrival to hospital, you do want to clamp and cut the cord and collect the placenta in a bag or somewhere safe to give to the receiving hospital. Thank you very much for watching. I hope you enjoyed.